Hey everyone. Good to see everyone. Most of you guys know who I am. So I'm Laura Lander. I'm social work faculty in the Department of Behavioral Medicine and Psychiatry. And I think the topic today was requested in last year's configuration. So hopefully it meets people's needs and is what people are looking for. Can everyone see my screen?
Yes, ma'am.
Great. So we're going to talk about, this is not a research heavy didactic. This is really an applied skills heavy didactic. So I don't have a whole lot of references. Really going to talk about skill building as it relates to treatment for substance use disorders, and also how to build self-efficacy in that context of skill building. So we'll cover in general a couple of different areas of skill building in the areas of cognitive, behavioral, interpersonal, and relapse prevention specifically, and then strategies on how to promote self-efficacy. And that's really done through successful skill practice. So these two things often go hand in hand, as well as building social supports, and a little bit about social learning theory and how that relates. So I am happy for people to jump in and answer questions throughout. I know, hopefully, do we have a case today?
No, we don't have a case today.
So I am happy for people to present like off the cuff cases. So if you didn't have time to submit one, happy to discuss any cases. So I don't just keep rolling along, and Elizabeth and Mitra can help monitor the chat, or if you want to raise a hand or just jump right in, that works too. So when we think about skill development, there are lots of different areas, and this is just general skill development that help with skill development. Training is certainly one. So first we need training to get the knowledge of what skills we need and how to apply skills in certain situations. So that kind of advanced training and knowledge and learning, which is the lower quadrant. And then we need practice. And with practice, I see that as experience, ability, and growth, that quadrant, practice and tolerance of failure, actually, and that's related to the efficacy, tolerance of failure, cheerleading, even though we didn't do it right, let's just say, people encouraging us to try again. So just a little bit of context on skill development in general. And that is applied to substance use disorders. We want to make sure when we're teaching skills and when we're asking people to apply skills, that they are connected to where they are in the progression of their recovery. So this is a triangle. I found this graphic really useful to talk about the different stages of recovery. So when someone is in the transition stage, we are not necessarily going to be working on a whole bunch of interpersonal skills. That needs to come later, and it is a very important skill, but often they're really unstable during this period of time. They're just trying to get through the day, or as people say, the moment, I'm just trying to get through the next 5 seconds without using. And so we're teaching other kinds of skills. So in the transition, stabilization, early recovery, and middle recovery. And so these goals are related to the kinds of skills that we're going to be teaching. Developing motivation. Oftentimes people have a lot of ambivalence in the transition stage. We're asking them to change so much, and that can provoke a lot of fear. And so that maintaining that motivation in the context of fear and ambivalence can be a struggle. So helping them resolve that fear and helping develop motivation. In the stabilization phase, we're going to be getting people attuned to what's happening right now in terms of when you remove a substance, what does that look like? Often people have a tremendous amount of rebound emotions. They're not used to feeling emotions. They're used to feeling numb. And so what do I do with all these emotions? Or they become highly symptomatic from a pre-existing mental health disorder, or a mental health disorder that was really exacerbated or created by their active substance use. And so that's the stabilization phase. Do people need medications? Do people need mental health treatment for co-occurring substance use disorders, and providing that kind of treatment and skill building? And then in early recovery, focusing on thoughts, feelings, identifying emotions is a big skill that people often have no idea what they're feeling, or they're feeling so many things all at once that it's very hard to tease out. And then it's really not until early to middle recovery that we're working on those interpersonal skills. And then late recovery can be some deeper work, especially regarding trauma and early childhood experiences, to focus on sustaining recovery and the kinds of things that may lead to a recurrence in the future. So these are the cognitive skills that we'll often talk about. Identifying emotions is huge in general. The general context of mood regulation, identifying emotions is where I usually go to first. And there are all kinds of graphics that can help with that. There are activities that can help with that. People, one of the things we do in groups is people will share an event that happened to them in the last week that produced a strong emotion. They'll identify the emotion, they'll describe the event, and then they'll talk a little bit about what skills they used to regulate. So if they were very angry, what kind of skills they used not to make the situation worse by like cursing someone out or whatever the situation might have been. So identifying those emotions, and then what skills do we need to teach to reduce reactivity? My favorite reactivity reduction skills are often, I often go to slogans, so that's below in the thinking change, but pausing. So pausing before you do anything. Sometimes that requires removing themselves from the situation in order to create a pause because they're so triggered by whatever the stimulus is. So teaching those kinds of reactivity reduction skills. Increasing the awareness of the emotional narrative. So this is like what is happening in their heads that is fueling the emotional reactivity. What story are you telling yourself about what's happening, or what it means that that person called you whatever they called you? So often people are not aware of these narratives, including shaming statements, a lot of self-criticism, a lot of self-hatred, that are messages that are just kind of running on a tape in their heads. And once people get sober, they can have a greater awareness of what those messages might be. They're usually very negative messages. And so we introduce some of the thinking skills about how to change those messages. And also changing the emotional narrative, like this always happens to me, this never happens to me. All those extremes that people that drive negative emotion for people. And then the thinking skills, my favorite thinking skills are slogans. So people can choose any slogan that they like to help them with a more positive thinking. Does anyone have any favorite slogans that they work with around changing thinking?
I'll keep an eye out for the chat as well.
Okay, people can also just shout it out. So my favorite one is progress, not perfection. So for people who are very hard on themselves, and if they don't do it right the first time, it means they can't do it at all. That's kind of a narrative that often people have. Progress, not perfection, can help to change that kind of narrative.
We had one in the chat from Laura saying, stinking thinking. And then Dr. Gorby says, one day at a time.
And do you guys want to, Laura, how do you use stinking thinking as kind of a skill?
We use that to identify when they're in a negative thought process. So it's thinking, you got to turn it around. Yeah,
so I kind of almost like mood identification or negative thinking identification, and then how do you flip that? Yeah, great. And Dr. Gorby, one day at a time, how do you use that?
Yeah, just to kind of get them to live in the moment, not worrying so much about the past or focusing too much on the future, but just taking care of what's in front of you and the mindfulness idea.
Yeah, and that's, I think, both connected to thinking change as well as mood regulation. So when people, I always think about if people are prone to depression, they spend a lot of time in the past. If people are prone to anxiety, they spend a lot of time in the future. And we're trying to help them get focused on the present, because those mood states often can result in self-sabotage and negative changes in motivation to stay focused on recovery and abstinence. So that's a good one. Reframing is certainly a cognitive skill. So identifying that narrative, and then what else could you say to yourself? What else could you tell yourself? Sometimes we ask people to, do they have any cheerleaders from their childhood or current cheerleaders? What would that person tell them? This can also include a little bit of grief work. Like, so if they have a grandparent who was the most important and supportive person in their life, and they've identified that, you can say, what would your grandmother tell you? Because oftentimes we carry the voices of people from our past with us, and they're very much in the present. Sometimes there are negative voices, but sometimes you can cultivate those positive voices too. So that can be a way of reframing. Focusing on gratitude is a pretty basic thinking change skill, whether that's having a gratitude list, that writing down 3 things that you're grateful for in the morning or right before you go to bed, or even when you're having a really difficult moment and you feel like everything's gone to hell, that what am I actually grateful for today? What do I have in my life today that is positive? So really teaching that as a skill. And then certainly another skill, don't believe everything you think, is a reference to cognitive distortions that people can be engaging in. So for those of you who have some cognitive behavioral therapy training, we think of automatic negative thoughts. People want to get in touch with those and then be able to, as Laura was saying, kind of flip them. So first you need to understand that it's always running there in the background, because people are sometimes not even conscious of that negative feedback loop that may always be running. I can never do anything right, I'm a failure, whatever those messages are. And then really actively inserting more positive messages. And when people say, oh, that's, we talk about affirmations, when people say, oh, that's ridiculous, what, I'm going to walk around like thinking I can do this, or someone that people look to, whatever affirmation we're trying to get people to incorporate that's a positive affirmation. And I say, well, don't you have negative affirmations running all the time? And they can rattle those off very, very clearly. So for our folks that have grown up in families where there's been a lot of invalidation, shaming, blaming, not to mention physical, sexual abuse, they have messages from their past, from their family of origin, often running in the background. And so it's almost healing that person within who didn't get that as a child, and being able to give that to themselves in the present. And I'm happy for people to share examples of how they might do this with their own folks.
Nikki had chatted in saying on that previous slide, when we're doing our 3 good things, I always say, when in doubt, look around and get them to find good things at a basic level.
Any basic level examples, Nikki, that where people find good things?
Like the sun is shining, you're under a roof, you're wearing clothes, you've eaten today.
Yep.
Things like that.
Yep, even breathing. So if I spoke to my mother last night, and a good friend of her was on a ventilator. So it reminded me of, the things we take for granted, like breathing on our own independently, or being healthy. So I think, yeah, those are great examples that we often overlook, but are essential to our basic needs. So some of the behavioral skills include journaling, And I always give these as examples. Not everybody likes to journal, so it's not like you have to use this skill. The goal is for people to have a wide range of skills that we teach them that they can choose from. Some will resonate with them and some will absolutely not, and that's okay. But when using substances has been the solution and has stopped being the solution, it has often been the primary skill that people turn to again and again and again, and they've lost their other kinds of skills that they either may never have developed because they started using when they were very young, or they stopped using because substances seemed like a really good solution to a lot of things, at least initially, early on in the progression. So another behavioral skill is progressive muscle relaxation. We certainly teach this. And sometimes people take to it right away, sometimes people don't, but I always frame it as a practice. Sometimes it feels like weird and goofy at first, and other people it really feels very helpful from the beginning. Mindfulness skills are something that we teach. So like Dr. Gorby was talking about, being in the present moment is one mindfulness skill. I always add in without judgment. Because mindfulness is comprised of both being in the present moment without judgment. Because sometimes what happens to people when they're only in the present moment is a whole bunch of negative thinking, and that doesn't help them necessarily. So there's some evidence-based interventions, mindfulness-based stress reduction, mindfulness-based relapse prevention. So those are some evidence-based practices that have workbooks where you can really teach these skills to patients. The other important thing that I remind myself and other people about mindfulness is it is a practice. And a lot of people say, oh, I can't do that. Oh, I can't clear my mind. Well, none of us can clear our mind very well. On any given day, I'm terrible at clearing my mind. But the more I practice mindfulness, and it's really about observing what's happening internally, not necessarily about like Zen clearing my mind, but being aware, being in the present moment, and working on not being judgmental. And that really takes practice. Daily practice is ideal, but any amount of practice that people can engage in, we can encourage. Peer recovery support group meetings helps a lot with skill building. The 12 steps obviously are centered around skill building. Reading recovery literature. For people who haven't read recovery literature, it's really important. I often incorporate reading, from some of the daily readers in group. That can be helpful to remind people to go to recovery literature, because sometimes if they're really using their peers or their support people and those people are not available, recovery literature can help with behavioral change and thinking change. Developing healthy habits. So again, these basic habits of really talking about nutrition. When we talk with patients about some of the things they're eating, the amount of sugar, the amount of caffeine, it becomes really clear that that may not be serving their recovery. So making sure we're talking about eating, or that they're eating once a day, that can be really problematic as well. Do people have access to nutritional foods? If they don't, how do we help them figure out both what healthy foods are and how to increase their access? So for folks in really rural counties, oftentimes there is no grocery store. There's like a dollar store, and dollar store does not have fresh produce and fruit. And so it can be challenging to figure out how to be healthy when you don't have great access to sources of food. Sleep. Lots of problems with sleep in early recovery. So we can talk about, for anyone who's taken the CBTI, so the CBT for insomnia, that's a great program. There's some basic skills that when I took it, I really learned. If assuming people have enough space in their living space, not to spend a lot of time in their bed, not spending a lot of time in your bed is one of the basic sleep skills. So the bed is for sleeping and for sex or whatever you might do sexually in your bed, but it's not for hanging out and spending a lot of time, because that actually impairs good sleep. So you can teach them those kinds of skills. Exercise. Sometimes if people are feeling physically very unwell, exercise can be extremely difficult, and that's not something that appeals. But even getting outside, going for a walk, small steps towards being able to engage in some kind of exercise routine, and then building that over time. And then recovery habits. I usually do groups on recovery habits, and I get all the group members to share what their recovery habits are, what they've put in. It's often what they've put in place of active using habits, or people come up with like the most creative things. So I love when they share that with each other. I don't know if any of you guys have some good examples of recovery habits that you use or that your patients have shared with you. No, the ones I find the most interesting are often people really incorporate their pets into their recovery, and it becomes very important that they are accountable and reliable to their pets. So they have often a morning routine around taking care of their animals, or an evening routine around taking care of their animals, and a sense of contribution to something that they love and that loves them, and that creates really meaning in their lives. So I've heard some great pet stories. Taking care of financial responsibilities. This can often be daunting when people are in the wake of not taking care of their financial responsibilities after being in active addiction for a long time. So helping people break that down into manageable pieces, and also accessing resources if they need financial help, and the resources that can help them with those. And then finding employment is huge. Do people need skills to be employable? Do people know how to be employable? Are people able to sort of wake up and get to a job on time? So depending on where they are in their employability, it depends on what kind of skills you might be teaching. So this was just kind of a graphic that's a little bit busy, but I found interesting really because of the active coping on the outside. So there's some examples of negative coping, and then the active coping is really just a list of coping skills that we can teach. And then the interpersonal skills. So interpersonal skills do come a little bit later in recovery, typically. And often people want to rush these. So I run a multifamily group as part of our intensive outpatient program. And patients often are very eager to want their family member to forgive them for the difficult things that they've been doing, or the ways that they've hurt their family members. And this is not going to happen in the first 3 months of recovery. Family members are often not ready to forgive, and family members are in a lot of pain. So interpersonal skills often take a little while, because that mood regulation, ability to pause, get out of reactivity, needs to come before the interpersonal skills can be effective. We teach effective communication, and I usually frame that as listening so that others will talk, and talking so that others will listen. And what does that look like? We teach nonverbal listening skills, and have people increase their awareness of how important that is. Obviously, that's one of the things I struggle with on video, is you cannot see what I'm doing with my hands if my hands are below where the camera is. And so you lose a whole bunch of nonverbal cues when we are on camera. Or when we are texting, we lose a whole bunch of nonverbal cues. We have emojis that can hopefully convey some affect, but in general, texting can be so open for misinterpretation because of the nonverbal cues that we're not seeing. So effective communication is an important interpersonal skill. Empathy and compassion, helping people understand what that is, helping them develop it if they struggle with it. So I do a lot of teaching about empathy and compassion actually with healthcare providers who work with individuals with substance use disorders. So last week, I actually just spoke to a bunch of nurses in our OB department, and they talked about burnout, and they talked about patients in active addiction who come to deliver their babies and they've not received any treatment, and their own struggles with their own emotions about that. And then if the patient is struggling on the floor and acting in a way that makes it difficult for the nurse to do their job, they have a lot of trouble getting in touch with compassion, and they're just generally pissed off at the patient for hurting their baby and creating a bunch of chaos on the floor. And so we talked about, how do you develop compassion with a patient that you're finding a lot of difficulty with? And so we can also teach patients how to develop compassion for whoever they're struggling with in their lives, including themselves. So what I see with our patients is often they have very little compassion, self-compassion. And there are actually mindfulness meditations and activities around developing self-compassion. So that's usually what I end up talking with patients most about. And the more compassion we have for ourselves, the easier it is really to have compassion for others. Conflict resolution, often patients have no models for conflict resolution. They grew up in families where there was lots of conflict and they didn't see it resolved effectively. And so teaching people those kinds of skills, can I be mad at someone and love someone at the same time? How not to engage in unfair fighting. So this is specifically relevant to couples work. So I don't know if anyone's familiar with Gottman and his work. He has the 4 horsemen, which are predictive of whether a marriage is going to be long-term successful or not. So one of the 4 horsemen that is the most destructive is contempt. And so speaking to someone that we love with a lot of contempt can be really, really destructive long-term and hard to repair. So when we think about it's okay to fight, how do we fight fair? How do we fight without insulting someone's sense of self, like who they are? But say, I don't like it when you do this. So often we'll teach I statements. So I feel sad when you disappear for hours and hours because I don't know where you are, and I'm concerned that you've relapsed, or some version of that. And then what the need is the 4th part of an I statement. So teaching those, practicing those. The thing about I statements, people are like, oh, who talks like that? Nobody talks like that. I'm like, exactly. But what it does to talk like that is slow you down. So you're so focused on thinking about how do I do this I statement that they get out of reactivity, and it helps them pause. So it kind of has 2 functions, not only communicating effectively, but slowing the communication process down when people are heated. It's important. Collaboration. So how do people work together? Again, people may be coming out of relationships where they've been spending a whole bunch of time lying, hiding, in an effort. Often people say, oh, I did it because I didn't want to hurt my loved one. And so how do we help them not engage in those behaviors that they've been repeating over and over again, and their loved ones have typically found hurtful? Perspective taking. So in our family group, we do a lot of that. So we have people share their perspective. So the family member's perspective and the individual in recovery from substance use perspective. And one of the things that often comes out is like, the reason I lied was because I didn't want to hurt you. So the family member didn't necessarily realize that. They're like, I just thought you lied because you wanted to go out and get high. And in fact, the person was lying in order to protect the person that they love. So that's like an example of sharing a perspective that people may not have been aware of. And then boundary setting. So we talk about boundaries a lot. Oftentimes when people get into recovery, they don't know what boundaries are. They don't know how to set them with their own family, especially if they have family members who are still actively using substances. How do I set boundaries, which may mean I have really limited time with my family because they're not safe for me to be around if I'm trying to be in recovery. So I'm gonna take a pause. Any thoughts or any comments in the chat before we move into self?
In the chat yet, but I'll keep my eye out.
Okay. And then relapse prevention skills. So you guys probably are pretty aware of relapse prevention skills. The primary skill is really having the awareness of what their warning signs and triggers are. So we'll talk about what are your warning signs and triggers, certainly avoiding people, places, and things whenever possible. It's not always possible, especially if you live with people who are still actively using, but how to reduce the risk if that is happening. And then developing plans for dealing with high-risk situations. Sometimes if you have to go into a high-risk situation, taking someone safe and in recovery with you would be a skill that we teach. And then practicing recovery thinking and behaviors, which is another place where slogans can be super helpful. The other piece is really putting relapses or recurrences of use in context. So it does not mean that someone has to return to active addiction long time. It can be an isolated incident, a slip, and people can get right back on track. And the best way to do that is to have some skills in place to reconnect with recovery community or treatment or whatever people are doing to stay well. And learning from the relapse. The question I often ask is, if you had this to do differently with the information you have today, what might you do differently? I think about there's a road to relapse. So relapse is not an event, it's a process. So there are many points along that road where people can get off the road to relapse and prevent a relapse by doing something different, thinking differently, or even having self-compassion if one of the drivers behind a recurrence is really self-loathing.
Dr. Gorby had mentioned AA helps with boundary setting.
You want to say more about that, Dr. Gorby?
Yeah, can you guys hear me?
Yes.
Yeah, I was going to just say the Al-Anon, really helps with codependency and setting boundaries, like that we didn't cause it, can't cure it, and can't control it, and detaching with love. So that's really helped me a lot with boundary setting as Al-Anon meetings.
Yeah, and many people who we work with grew up in families with active substance use. And so once they get stabilized in their own recovery, oftentimes sponsors or other people in their life will actually recommend that they also go to Al-Anon meetings because yes, Al-Anon meetings have lots of focus on boundary setting and detachment and detaching with love as opposed to an X. Usually people need pretty stable recovery before they move into that, although if their recovery is stable enough, certainly the skills are really important and the steps are almost identical. So this is just a quote about relapse. There's no shame in beginning again, for you get a chance to build bigger and better than before. And then this is one of my favorite quotes about, it's an English quote because they spell tires like that, about the patient. When I share this with patients in group, they like this one. Giving up on your goal because of one setback is like slashing your other 3 tires because you got a flat. Don't give up and repair. So framing relapse and relapse prevention or recurrence as an opportunity to repair and build back stronger versus a failure. So I just also wanted to talk about 12 steps as skills. So we really do encourage people to go to meetings. Not everybody does, although there's lots of opportunity for online meetings all over the world. And so we didn't used to really have that much opportunity before COVID. That's one of the gifts of COVID is access to meetings. And this is just kind of a list of what skill goes with what step. And then moving into self-efficacy. Self-efficacy is also a process, and I particularly like this visual image because it highlights that it's not like I either have it or I don't. People move up and down on these steps depending on the difficulty of the situation, or if this is a thing they've encountered or not before. But it starts out with, I won't, I can't, I want, I do, I try, I can, I will, and then that I did it. And it is in the successful doing that self-efficacy has built, but it is in the process. People have to engage in the process in order to build it. And sometimes we fail, and that doesn't mean that self-efficacy can't be built in a specific skill, or like just feeling like you can handle whatever life throws you. So I'll often talk about, any skill we build, whether it's soccer or learning woodworking or learning how to paint, we get better with practice, and recovery skills are no different. So groups give us great opportunity to practice interpersonal skills as well as other skills, as do kind of family interventions if you're doing any family work or couples work. And accountability is important. So sometimes having someone observe you engage in the skill is kind of what I mean by accountability here. That can be helpful because they can give you feedback, they can give you praise, they can say, this went really well, and I wonder if you could do this a little bit differently. That can really help with building self-efficacy too, because monitoring that progress and recognizing successes is super important, as well as some cheerleading along the way. So this is just a graphic about the process of skill building. First, you have to engage in the activity. Many people are highly avoidant of uncomfortable situations, which is where we practice skills in uncomfortable situations. And so helping people get comfortable practicing is important, creating a safe place where they can practice, whether that's an individual therapy or group therapy or in social settings, and then reporting back to us. So that progress and feedback can come from us, or it can come from other social supports. And then like the investment in keeping and trying, keep trying, even if it didn't go exactly the way you wanted, because most people like painting. I'm not going to sit down and learn how to paint and do it really well at first try. So there's no reason that recovery skills should be any different. I also really liked this graphic in terms of the window of tolerance. So if we're going to practice a skill, it's easier, or the outcome is more likely to be positive if we don't do it in the most stressful, horrible situation. So the other thing about when we encourage people to practice skills, we want them to practice in a setting where they're likely to have a positive outcome. So you don't practice with the person you're getting along with the worst. If you're working on an interpersonal skill, you practice with someone you're actually getting along with okay, and that can build that self-efficacy because they're going to have initial success versus, practicing with your father who you haven't talked to in 10 years and you have a lot of resentment towards. So for those who are familiar with Albert Bandura, he's really the forefather of social learning theory. And this quote from him is, in order to succeed, people need a sense of self-efficacy, to struggle together with resilience to meet the inevitable obstacles and inequities of life. And again, I'm a big, you guys know I'm a big group person. So this to me also highlights the value of working in groups, whether that's therapy groups or family groups, because common struggle definitely builds connection, cohesion, and can build resilience. And so this is the other reason why self-help groups can be so important. Typically, people know that other people are struggling, and so give them some grace if they don't sort of execute their skill perfectly, and also can provide that feedback that can help with self-efficacy. And then this little image of the recovery warrior, I really liked. that people have been through a lot in their active addiction, and to sort of remind them of that. So I have a patient who she came into treatment initially, and she's like, I haven't had any trauma. There's no reason I should be this sick in my addiction. And as we really talked about the life and the things that had happened in her life, she had many traumatic things happen to her, but she said, but it was my own fault because I was actively using. So she really blamed herself for sexual assault because it occurred when she was under the influence, and she didn't give herself enough self-compassion and grace to recognize, even though you may have put yourself in a situation in which it was likely that you might have been assaulted, that doesn't mean it wasn't a trauma. And that doesn't mean that was like what you wanted to happen. So certainly we see this with women who end up feeling like the only way to sustain their active addiction is to, say, get into sex work or get into situations in which they would tolerate things that they would not normally tolerate in sobriety, or I mean, that they really feel like they have no other option because they don't see a way out of the addiction. And so they end up in situations in which they're compromising their own values. So people have been through a lot. So that is presentation. So any, I mean, I'm happy to talk about any patient examples, client examples of skill building, or any group activities that you guys do to build skills, just to share that with the group.
Thank you so much, Laura. As always, we really appreciate your time and sharing your expertise with the group. I really just love all the quotes that you include. They're so impactful, and they really hit home. And I am not even part of any clinician type of field, not even remotely close, but it is so impactful. So thank you so much. And I'll echo what Laura mentioned about if anyone has any informal cases or situations that they wanted to bring up with the group, you're more than welcome to.
So I know Dr. Gorby also mentioned medication-assisted recovery anonymous stresses non-judgmental supports, patients taking meds for OUD. So actually, thank you for mentioning that, Dr. Gorby. So we actually restarted our BUPE group, which is based on medication-assisted recovery anonymous model, and it is virtual. So I will meet her, Elizabeth. Have we shared that flyer with folks? Do you know?
We may have in the past, but if anyone has access to it again, I'm more than happy to share in the recap today.
Okay, I will, after we're done, I'll send you that flyer. So we are hosting it on Zoom, and anyone who is on MOUD is welcome to come. And it is that, non-judgmental environment. Currently, our recovery coaches are helping to facilitate that meeting.
Laura, if you don't mind, I was going to read the MARA preamble.
Absolutely.
So it says, Medication-Assisted Recovery Anonymous is a support group of people who believe in the value of medication as a means to recovery. We understand that our individual needs may not be the same, our backgrounds may not be the same, our futures may not be the same. However, our desire to live a safe lifestyle joins us together. Non-judgment is our code. Thanks for letting me read it.
Yeah, wonderful. Thank you for reading that. Yeah, because we certainly have had feedback over the years. I think it's better than it was, but it's not necessarily where it needs to be with regard to NA and AA being supportive of those on medication for opioid use disorder and other medications. So I welcome, like, off the cuff, client examples.
One thing that's, Laura, one thing that's really helped me is the martial arts, and it teaches a lot cooperation and self-discipline and becoming part of a group, and you actually learn to control your temper and reduce fear and things by studying martial arts. And I would just like to, I've been trying to, get my patients and stuff to try it out, but it's been really difficult to get people to try it.
And I would argue it also builds self-efficacy, right? Because you're developing a skill, you're seeing progress, and it's kind of there's a mind-body connection in martial arts or yoga, other kinds of body activities. I don't know, do you think it's people don't have the financial resources, or that it just seems kind of
I've even offered to, my sensei and we've even offered to do it for free.
Wow.
Yeah. And we do the one I really like for recovery is Aikido. It's blending and harmonizing with energy and with each other. And it's all about kind of a spiritual martial art. And it's coordinating with your partner. It's not like kicking and punching and striking. So it's really good for recovery, in my opinion.
Thank you. Any other thoughts or comments?
I was also going to encourage everyone, if it's because of the recording, I'm happy to cut out that portion if you're more inclined to share something with us stopping the recording. So I'm just going to put that out there. So just let me know. And Laura, I love that you brought up the example of having pets and that responsibility and that sense of routine almost. It really does help. And I'm sure even having plants helps some folks too. You have to water them consistently so that, they bloom or stay alive. So that was really interesting to me. Thank you, Jen. Jen Boyd chatted and thanking you, Laura, for the great presentation.
Sure, no problem.
Any other comments, questions, or thoughts?
I will be sure to send the view group flyer to Mitra so she can send that out.
Perfect. Thank you so much, Laura. All righty. Well, if there are no final questions or comments, thank you all so much. And thank you, Laura, for your presentation. We really appreciate you. My only announcement for today is that our next session will be on May 22nd, and Katie Shazon Downs will be presenting on policy and best practices. So we look forward to seeing you all next time. Thanks, everyone.
So actually a question just popped in, sorry.
Oh yeah, of course, thank you.
So Richard just asked about what do you recommend for first step with patients in skills. So it depends a little bit on where patients are at. So that first step sometimes is really around sustaining motivation for abstinence or motivation for engaging in treatment. Because sometimes people that's where they're at. They're like, I don't think I need to do this, or I don't know if I really have a problem. So for some people, it's looking at the increasing awareness around the consequences that their substance use has caused for them. Some people rationalize, oh, that's not that big a deal, or I still have my job, or those kinds of things. So that might be where you start with skill building. Or the other place, if people are engaged in successful abstinence, but are completely overwhelmed with either feeling sick mentally or physically, that's often where we'll start, is like how to build back some positive experiences of their physical self, their emotional self, and that stabilization phase. So whatever will help people feel more stable physically, emotionally, or in their engagement with recovery.
Thank you for that question, Richard. And he was saying he has some issues with his mic, so I'll give you a moment there if you wanted to chat back anything.
So he said, I have a patient that is on higher level and stable and feels does not need therapy. Higher level, I'm not sure what higher level is, but like, it sounds like more progressed in their recovery. Okay. So that's really where the deeper work can come in, although that's scary. And so that's where you can actually do like therapy with people. That's the place where I love working with people, because they're not just struggling with day-to-day, oh my God, how do I get through this day, right? So you can, at that stage, often looking at the interpersonal skills is where you can get some engagement. Are there any relationships in their lives that they're struggling with, or any kind of patterns in relationships that they've noticed? And also, I mean, my particular theoretical bias is family origin work. So beginning to talk about the families that people have grown up in and the experiences they may have had in those families, and how that has influenced whether it be their substance use disorder or their emotional functioning in relationships, attachment relationships. That would be a place that I might encourage that patient to go if they were willing. Thanks for the question.
Thank you, Richard. We'll give it the echo pause here in case there are any other questions from the group. Alrighty, and as always, oh, I see you and
I think I got my mic to work.
Yes, we can hear you. That's awesome.
How much measurement-based care do you do? Do you use the BAM and the PQ9, and do you use those other things? And do you have them do any of that stuff before you see them?
Yeah, so before COVID, we regularly administered the PHQ-9 and the GAD-7 and monitored that in treatment. During COVID, we got away from that, but Jeremy, you'll be happy to know, I met with our students and they're all about like collecting that data again, which I was really excited to hear, because I think it's highly valuable both to evaluate effectiveness of treatment as well as document success. So what we used to do, which I love doing, was to collect their scores over the course of, say 3 months of treatment, and then graph those scores for them and show them, what they looked like. Now, sometimes people have lots of ups and downs, and that's okay. And we can talk about what does that mean, and vulnerability, and what do you do in those more vulnerable spots. Some people have like a trend line that goes straight up, and that's always great to be able to show them that kind of progress. So measurement based care, I think, is highly valuable in building self-efficacy.
Excellent.
I think the trick with it is making it like a normal part of treatment, and not letting it interfere too much with the clinical work. Because if you spend 5 minutes of your visit just doing this stuff, it can really feel weird and awkward. So it's sort of, if you can have like an MA administer it or somebody else right before the visit, that's ideal if you're going to do it. So.
I saw a clinician, I think it was from ASAM, that had used measurement-based care, and he had I think he had a lecture on it, and he said to have them fill it out before they come in.
Yeah, that's what we used to do. Yep.
Yeah, beforehand. He said it was a real valuable tool, but he did say that not to spend all of your time on that, of course.
There's a lot of them, yeah.
Yeah.
Makes for boring conversation.
Yeah. Yeah. So hopefully if people are willing to do that in advance, that certainly is ideal. All right. Well, thanks, everyone.
Thank you very much.
Sure.
Yeah, thank you all so much. And as always, if there are any questions after the session's done today, you can always email me as well. So Thank you, and we'll see you all next time. Thanks, guys.
Yeah.
Take care.